introduction. So we'll get started. Welcome, everyone. I took the liberty to change the title just slightly to reflect a little bit more the kind of the gist of the talk. Um, the main reason for that is that honestly, I can't really define for you quite accurately what a hypotensive neonate is. That's as we'll talk more about. My plan is to describe a few key features of the fetal and transitional cardiac physiology, and then go over some basic physiologic principles that govern blood flow and circulatory failure, and then delve into the vasoactive medications, go over their mechanism of action, indication, toxicity, and then go over what a hemodynamic appraisal would look like. So why do we even care about the subject and talking about it? Because, well, brain matters and for all of us and for our patients. And the cerebral blood flow is truly a complex interplay between the systemic and the pulmonary vascular resistance, the cardiac output. And we have the great privilege of taking care of these babies during their transition, where they're at greatest risk for intracranial complications. And it's not just biologically plausible. It has been actually published from one center, at least, that normalizing the physiology in preterm babies at the beginning of their life actually reduces their risk of IVH and improves their outcome. And then heart matters too. We, recently, and now it's been in the past few years, have learned that young adults who are former preemies have different hearts. They're smaller. Their LV and RV function is impaired. They have increased kind of myocardial fibrosis, who puts them at about 17-fold increased risk in heart failure, and especially if they're less than 28 weeks, and 1.5-fold increase in ischemic heart disease, and that happens early in adulthood. So we sure hope that if we can mitigate some of those early interventions that we do in the NICU, we can maybe modify this this impact in their young adult life. So let's start back with the fetal physiology. A quick overview: the RV is the dominant ventricle that supplies about 2/3 of the cardiac output, mostly to the lower body. The LV does the other third, and its upper body and brain. Interestingly, the nature has it that way, where the saturations are slightly higher in the LV, we don't know why, but probably to protect the brain when compared to the RV. And then most of us know that 10% or about there of the cardiac output goes to the lungs. And the fetus is quite adept at this hypoxemic environment, does well in it. Has fetal hemoglobin, which has high affinity, and then it has increased oxygen carrying capacity through epoprotein and a hematocrit that's increased, and decreased oxygen consumption because the mom takes care of a lot of the thermoregulation and the effort of providing respiratory effort and digestion. Now, what must happen for effective transition? So, of course, the cut from placental circulation has to happen. We need an increase in pulmonary blood flow, the separation between the systemic and pulmonary circulations. And for PDA, that means increased oxygen, lower PG. We clamp the UV, and then oxygen helps with involuting the umbilical artery as well. And we need to switch those ventricular roles. So LV needs to become the dominant ventricle. Now, the preterm myocardium, so when we're talking about the preterm infant, operates very close to its physiologic capacity. And what do I mean by that? It has reduced contractility and easily overwhelmed. Structurally, it's different. It's disorganized and immature. And then functionally, it's poorly equipped to deal with additional stress, especially the afterload. And there's an immature adrenergic system, and I'll talk a little bit more about it and show you a graph. So the adrenergic receptors appear first, the alpha 1, the beta 1, and then this favors peripheral vasoconstriction and this susceptibility to afterload. And then we have the intra and extra cardiac shunts that the premature infant has to deal with. So it's simple. The red blood cell does not, it's not intelligent. It goes where the path is of the least resistance. It truly happens that way. And if we go back to Ohm's law in physics, we know that flow is governed by the differential in pressure and then the resistance that you have in that specific system. So knowing what your PVR and what your SVR, so pulmonary vascular resistance and systemic vascular resistance, tells us, and the pressures in the system tells us which way the blood flows, and that's nice because we can then manipulate the pulmonary vascular resistance and the systemic vascular resistance to increase either the pulmonary blood flow or the systemic blood flow, along with using the shunt if we have it to manipulate that blood flow. Hopefully this equation also helps you understand that an increase in mean blood pressure does not equal an increase in end organ blood flow. So I asked ChatGPT to give me an illustration of what hypotension means in preterm baby, and I think ChatGPT was confused as well. But there, the hemodynamic instability means that we have this non-specific fluctuation in one or more hemodynamic markers, and they're listed over here, that is outside the normative range, is what do we expect them to be. And this may or may not affect the end organ blood flow and hence the oxygen delivery. One thing is for sure, that hypotension alone does not equate to circulatory failure. It is only one of those multiple markers. So normally we have an imbalance between oxygen delivery and oxygen consumption, and this ratio is normally around 5:1. And so there's a redundancy in the system, in the delivery, that is an imperative to have there, because we need to be able to tolerate additional stress. For example, in adults, being able to exercise and doing other things. And if we go back to the equation of what oxygen delivery looks like, it is a cardiac output, and then also the blood oxygen contact that matters in the equation. Then if we break that down further, those are kind of the variables that we are able to manipulate. Of course, the heart rate, the stroke volume, and the hemoglobin. So whenever this imbalance shifts the opposite way between this oxygen and delivery and oxygen consumption, this is when we talk about circulatory failure. There's a tendency, and I have this graph in there because there's a tendency to use the arterial PaO2 as an indication of how much oxygen is in the blood. However, the content of oxygen is determined primarily by hemoglobin, as we see it in our equation. So a proportional decrease in hemoglobin, as you see from 15 to 7.5, it proportionally decreases your oxygen content versus a decrease in saturation and a PaO2 in half, so which would equate to a decrease in saturation from, let's say, 98% to 78%, only reduces the oxygen content by 20%. So that demonstrates that anemia has a much greater influence on arterial oxygenation than hypoxemia. Now, I think it's imperative to understand the determinants of cardiovascular performance. I think we're all very familiar and kind of think through the preload afterload contractility, the main scaffold, and the heart rate when we have a baby in front of us. But a lot of the times we don't think about the other determinants, which you see here on the left side. What are the fetal shunts? So we're talking about the PDA, the atrial level shunt, how the heart relaxes, what is the coronary perfusion, hemoglobin. I won't spend a lot of time on this, but in order to be able to correctly appraise the hemodynamics, we should all think about those. But I'll spend a moment on the coronary perfusion pressure, because I think this is forgotten most often. So it's a difference between the diastolic blood pressure and the left ventricular and diastolic pressure. So in order to optimize the coronary perfusion pressure, and we should think about that, especially in those babies with cardiogenic shock, we should focus on improving the mean arterial pressure, the systemic vascular resistance, and also have agents that decrease preload and filling pressure. And that is probably something that we don't think often when we have these babies. So 10 to 20% of neonates end up on at least one vasoactive medication in their first few days of life. And of course, later on, if they have complications, sepsis, and so forth. So we use them a lot. So we should all kind of take this ride on the roller coaster of learning them. As you can see in this graph, the kind of the perceived complexity starts here quite low. And then it suggests this initial optimistic outset. However, it quickly goes through various stages of confusion, realization, desperation, only to finally reach this level of understanding and where the actual understanding stabilizes. That's to say that it's a process and it takes a while to understand all the vasoactive medications. So you're not alone. We have all probably seen a version of this, and it's one of no specific target on this algorithm particularly, but we all have seen a version in our own NICU. I have one in our unit, and I've been tasked to updating it and sort of adding more to it, and making it still a fixed algorithm. However, I think the concept of one size fits all for vasoactive medications in the NICU is practically and clinically impossible because of this need for highly individualized response, carefully monitoring the treatment strategies, the individual variability of the patients, and frankly, the science and the medical evidence doesn't suggest that we can adopt a one size fit all. Otherwise, we would have had it already. So a good attempt to have a kind of a new integrated algorithm, physiologic based, and the measurement of hemodynamic instability was published not that long ago. And I'll have a QR code and a reference later on in my talk. But it looks something like this. So it is physiologic based, and it takes about 5 variables into consideration to kind of divide the assessment in 5 categories. As you notice at the bottom and here, we still have those situations where we need management or guidance from from a hemodynamic assessment and an echo assessment. So before I talk about the vasoactive medications, I definitely wanted to mention volume expansion because we use it still frequently in our NICUs. And just a reminder, the majority of preterm infants are euvolemic, and giving volume without having true hypovolemia does not improve cardiac output and blood pressure, and it has no effect on cerebral oxygen delivery, and it has been demonstrated to be to having increased morbidity and mortality in our preterm population. So quick memory trigger of the before we talk about the vasoactive medications, of the receptor, adrenergic receptors. And so beta-1 at the level of the myocardium will increase your heart rate, will increase your contractile force. We're going to focus on mainly this two, and alpha-1 causes vasoconstriction at the level of the smooth muscle, and beta-2 is a vasodilator. I like this illustration, and so I adapted it from a recent talk from Dr. Amir Ashrafi. I think because I'm a visual person and it puts in perspective, those are your vasopressors, and we use kind of the word vasopressor for all our vasoactive medications, but we should remember that they are, predominantly vasopressor or inotropes. the one that you see in the middle, the epinephrine, for the sake of simplicity, is in the middle. Can obviously it's both an inotrope and a vasopressor. So I modified this slightly to add our other medications that we use. And so you see vasopressin is a strong vasopressor, and then milrinone is an inotrope, lusitrope. It has many effects. As you noticed, our most popular drug that is used is missing. And that's because we broke up with it recently at PAS. For those of you who weren't there, there was a fantastic talk about breaking up with dopamine by Dr. Aubrey Hubbard. And why is that? Because it's unpredictable in our babies, especially in neonates. Has some concerning behavior that we'll talk about in just a moment, and it's already out of the use mainly in pediatric and adult population. So in our preterm babies, and I talked about this adrenergic receptor maturation. As you can see, the alpha one sort of gradually increases versus the beta one that has a slower increase and then peaks close to birth. So then the predominant effect of your dopamine in preterm baby at this lower dose is actually a vasopressin rather than an inotrope. And we use it most likely because we need the inotropy. And then when it comes to our near-term infants, it's really it's variable. It's all over the place. So it's not a clean drug. Let's go a little bit over kind of what are the clinical implications of our most popular drug. So it is a precursor of norepinephrine, acts on dopaminergic beta and alpha adrenergic receptors, and about 25% of it converts to norepinephrine, which makes it also a poor choice for long-term inotropic therapy due to kind of this eventual depletion of endogenous stores. And classically, dopamine was presented as a dose in kind of dependent effect. Unfortunately, in our population, I'll focus more on this column here. It is a non-specific vasopressor that increases the blood pressure. It does good at increasing the blood pressure, but it has actually a modest effect on cardiac output. So I put a link in there to one of the articles that talks, it's a comparison between dopamine and dobutamine in regards to cardiac output. One thing that we don't like about it is also that it has an unpredictable effect on the pulmonary arterial pressure and potentially may worsen pulmonary hypertension. So definitely not one that we should use in our babies with acute pulmonary hypertension, or those who have chronic or acute exacerbation of it. Now, dopamine used to be probably our second kind of go-to as a vasoactive medication. That has fallen a little bit down out of favor in third or fourth place, I would say, perhaps because it's not as easy to realize that it increases the cardiac rate, because the blood pressure doesn't increase as much in comparison to dopamine, and frequently you need measurements of cardiac output to actually evaluate its function. It is a synthetic catecholamine, and it stimulates mainly the beta 1 to increase the contractility. So it is best indicated in cardiogenic shock and vasoconstrictive physiology. So when you don't need that vasoconstriction, usually the heart rate is the one that increases initially, and then the inotropic effect comes after a little bit into 10 to 60 minutes into the infusion. And again, it doesn't change the systemic blood pressure and as much as dopamine and the afterload, but it is effective at improving the systemic blood flow. I would say epinephrine is now used a little bit more, and maybe it made it to the second place of our our favorite vasoactive medications. It engages all the receptors in a can, and it is a dose-dependent effect. Most of the times you'll see this reference of being 0.02 to probably 0.1. I would say for sure less than 0.05, you have more of this inotropic effect, which would be useful in cardiogenic shock. And in order to get the vasopressor effect, you have to go to the higher doses listed in here. At low dose, it increases your cardiac output more than the systemic vascular resistance. It does outperform dopamine in augmenting stroke volume, cardiac output, and cerebral blood flow, and systemic vascular resistance in preterm infants. Of course, at high dose, you can have excessive vasoconstriction, and that can actually decrease your cardiac output further. Norepinephrine, it is a powerful alpha adrenergic agonist. It probably, I would say now, if you ask several NICUs, it's probably a third, fourth line vasoactive medication. It is very effective in this refractory vasodilator physiology and vasodilatory shock with pulmonary hypertension. So for pediatric population, it's first line treatment in vasodilatory shock. And it may have some mild pulmonary vasodilation effect. The data is limited, but there's potential effectiveness in term and neonates with shock unresponsive to dopamine and dobutamine. So for those refractory shock infants, it may be helpful. And then the newer to NICUs, I would say, drugs, vasopressin. It acts at all those levels, V1, V2 receptors, and V3. For the V1 receptors, it's a potent vasoconstrictant in major organs. It does affect the kidneys collecting duct, with resulting in water reabsorption and regulating plasma osmolarity and blood volume. And then there's this theoretical advantage in hypotensive infants with LV diastolic dysfunction or hypertrophic cardiomyopathy through the V3 receptor stimulation. So effectively, it is a very good vasoactive medication in refractory vasodilatory physiology and shock with pulmonary hypertension. It increases the SVR and urine output. When you're stuck and you have resistant shock, despite many catecholamines, it does promote adrenal cortisol secretion together with ACTH and acts synergistically, sometimes with catecholamines, to bolster response. People run into the issues, and that's why I have the QR code here with hyponatremia. If your fluid management and sodium management is done well with it, or anticipating kind of the use of it, you will not necessarily see the hyponatremia. And that article is a great one to read in regards to use in preterm babies, and they weren't able to, they did not see hyponatremia as a toxicity. And then milrinone is a selective phosphodiesterase 3 inhibitor. It does help with left and right myocardial dysfunction, pulmonary hypertension, refractory to inhaled nitric oxide, and vasoconstrictor physiology. Has been shown to enhance right and left ventricular function post-cardiac surgery in the CDH population and PPHN, and also reduce post-operative, so post-ligation syndrome, post-PDA ligation instability. And it has shown to be improvements in oxygenation and RV function in very small babies with pulmonary hypertension. In our population, I would say we do not need a loading dose, as it is recommended in pediatric and adult population. Caution for this decreased clearance with renal failure and HIE when use. Just a quick Pearl, as far as remembering the how these two drugs act, I'm a visual person, so thinking about imlerenone as a 3-phosphodiesterase 3, and it works by increasing cyclic AMP, versus sildenafil looks like a 5. G looks like an S and a 5. It's increasing cyclic GMP. And then we do have to talk about corticosteroids. They're also very, they're used frequently in babies with circulatory failure. So they upregulate the production of the receptors, and they modify the messaging system. They help with increasing conversion for norepinephrine to epinephrine and breaking down of catecholamines. So they can also work synergistically. They can help with the capillary leak syndrome. And they increase the systemic blood pressure in preterm infants that have refractory hypotension. It takes a moment, takes about 2 to 6 hours to see the effect, as we've all experienced in the NICU. So I encourage you to have a version of this. I have a couple of them, and I still refer to them when I think about what I want the desired effect to be in a specific infant. And I am happy to share them, and there are some other resources available if you look for them. All right, so let's try to tie it all together and how we do a hemodynamic appraisal and manage the circulatory failure in front of us. I added this graph again to make us think about those cardiovascular determinants again. So normally that's how I would go through my mind when I see a baby that has circulatory insufficiency. So thinking about, is the cardiac anatomy normal? Is my rhythm normal? Do I have hypotension? And this is not just the mean arterial pressure, looking at the systolic, diastolic, or are they both? Thinking, is this a low or high systemic vascular resistance state, or my pulmonary vascular resistance is high or low? And then, do I have heart dysfunction? So this obviously is hard to assess without having the echo. And do I have a normal low high cardiac output? Again, I need echo for that. What are my fetal shunts, right? They're in there. Do I have a PDA? Is that an atrial level shunt? Do I have pulmonary hypertension? And then what are the medications are at play, or cardiopulmonary interactions that I need to be aware in that particular baby? So if you think about all this and put it all together in babies, most likely you will and have the advantage of having the echo assessment, then most likely will come to the right medication, being able to adjust that properly. So a little bit of, I had it in there in the prior slide. Well, blood pressure is a systolic, hypotension, diastolic. So I wanted to take a moment to go over the summary of evidence that we have. There is no evidence to support that mean arterial pressure, mean blood pressure less than gestational age is a reliable determinant of significant hypotension. There is a discrepancy between all references with the blood pressure values. I have a few that I use that I'll share in a moment that have normative tables per gestational age. I think that's helpful to keep in mind. A 22, 23 weeker will have different normative values. There is no known cut limit for low blood pressure that can actually predict clinical outcomes. And low blood pressure is not an independent predictor of clinical outcomes. And there's no single, I would say, blood pressure component that's considered the best predictor of outcomes. So whether it is the systolic, diastolic, pulse pressure. And when we talk about all the hemodynamic parameters, including hypotension, there's not one single reliable hemodynamic parameter for the clinical assessment. That's why we need several of them. So those are the few references that I use per gestational age. That's one of them that breaks down it looks at the third percentile thresholds based on gestational age. And this is another reference that also goes to 22 weeker. For you see this reference is for day 1, so early after birth, and then there's this reference that goes by corrected post-conceptual age to have references for the under 5th percentile, 50th, and the high thresholds. So let's go through some scenarios. I think hopefully it's helpful to apply this hemodynamic appraisal that I've talked to in a couple of slides ago. So we have a 24-weeker, it's a small baby, 500 grams, preterm labor, is admitted to NICU, had delayed cord clamping, the ABGARs are great, no maternal risk factors, intubated in the delivery room, and then soon after admission has hypotension. So if I think about, I talked about the hemodynamic appraisal. I don't have evidence that I have any cardiac abnormalities from my fetal ultrasounds, and then I don't see an abnormal rhythm. I just mentioned to you that this was a systolic hypotension, less than, using one of those tables that I just shared with you. And then now I have to figure out, is this a low or high systemic vascular resistance or pulmonary vascular resistance? And just looking at the scenario, obviously I didn't give you on purpose a lot of details, but the fact that this is a very fresh baby immediately after delivery makes me think, yes, this is a high SVR, so it has a high afterload situation. And this is essentially a failed adaptation and failed transition, at least temporarily, due to vasoconstrictive physiology. So how do I go about treating this? I do nothing and I wait, because most likely this is, this preterm myocardium that is going through the transition, and likely this will get better. If I have to, this is prolonged, and if I have to intervene, then an appropriate dose of inotrope. Some inotrope that does not have vasoconstrictive effects, because I told you at the beginning of the talk that the preterm myocardium really cannot sustain higher afterload. So I don't want anything that will increase my systemic vascular resistance even further after getting rid of the placenta. So dobutamine would be a great choice. In cases more complex and more complicated, milrinone could be used. So let's go to another scenario. I have a 28 weeker. Now it's corrected 31, presents with abdominal distension, our dreaded sort of dilated bowel loops, pneumatosis, is hypotensive, delayed bounding pulses. I know already I have normal cardiac anatomy, normal rhythm, and probably both of my pressures are systolic and diastolic are decreased. And now the question is, do we think this is a low or high systemic vascular resistance kind of scenario or not? And indeed, this is a scenario where you have low systemic vascular resistance and low preload because of this vasodilatory physiology sepsis neck. So how would you go about treating a baby like this? Of course, the underlying etiology is the most important, for starting antibiotics and addressing the infection, the sepsis. And then choosing an appropriate dose of vasopressor. I definitely need a vasopressor to maintain both vascular resistance and oxygen delivery. That would be, something like a norepi or vasopressin or high dose epinephrine. Just a quick reminder, then when you deal with sepsis and septic shock, you can have both physiologies, one vasodilatory and vasoconstrictive physiology that I shared in a similar example of in the first case. And in this case, you'll have normal blood pressure. You will not have hypotension. And let's take the same baby, the 24-weeker preterm labor that we admitted, same scenario, except now a little bit later, 48 hours after admission, has diastolic hypotension and low mean arterial pressure. I know already that I'm not dealing with the cardiac anatomy issues with rhythm. It is a diastolic hypotension. And then I have to think, do I have a low or high SVR or PVR, or what's going on in this case? And if I had to guess, most likely, I'm dealing with a fetal shunt, persistence of the fetal shunt, and it's a left to right at this point as my pulmonary vascular resistance decreases after birth. And then I would have to address what I can do as far as shunt mitigating measures to increase slightly my pulmonary vascular resistance to reverse this left to right shunt. And that includes some of the medications like Tylenol, and then eventually, if it's persistent, some of the more invasive intervention of actually closing the duct. Now I have now the scenario with a 31-weeker is hypotensive, has poor perfusion, high lactates, and requires quite a bit of dopamine. I'm up to, all the way to 15 or so of dopamine. My heart rate is 190, and I have persistent hypotension. So I didn't specify as a systolic or diastolic hypotension or both. The heart rate is quite high, and most likely in this case, it is the fact that I have a heart rate of 190 with a medicine that's increasing it even further. So I have this volume depletion or underfilled heart because it does not have time to fill because of that heart rate. So what would I do? I decrease the dopamine dose. If I have to use fluid resuscitation slightly with a small volume until I lower my heart rate and be able to get out of this, and then inotropic and chronotropic support would not be recommended in this case, because that heart is going to have a harder and harder time to fill and have a good cardiac output. Vasopressin could be used since it doesn't have any of the effect on the heart rate and no chronotropy if my blood pressure remains low. And another scenario, this is the last, and then we can kind of wrap up and think through this. So we have a full-term, non-reassuring fetal heart tones delivery via C-section. I have a poor Apgar scores, port pH is low, intubated and cooling. And then a few hours after admission into cooling becomes hypotensive, and it's both systolic and diastolic hypotension. What do I think I have to deal with right in this case? And this is a bit of a trick question, an unfair question, because a lot of those could be true. So yes, I could have poor myocardial performance. In this case, most likely I would, and it's most likely the right ventricle that's affected in HIE babies. But this could also be a relative adrenal insufficiency. This could also be an increased afterload because I am cooling the baby and I have high systemic vascular resistance. But let's say I just have a poor myocardial performance, so cardiac dysfunction that hopefully I was able to get an echo and confirm with. So I would treat the underlying physiology and an appropriate dose of inotropic effect. Something like dopamine or low dose epinephrine that would give me that inotropic and support that RV until it gets better and past this hypoxic hit. If we have a refractory postnatal cardiogenic shock, with ventricular dysfunction on one side, I also have this. I encourage you to think about maintaining that duct with prostaglandin to be able to manipulate that blood flow further, either to augment the pulmonary or the systemic blood flow. So all in all, we should try, and we all do, to not cause harm. We should titrate these drugs cautiously and for our desired effect. If we have no response or we have an undesired effect, we may be on the wrong drug that does not fit the pathophysiology. We may have some other coexisting dysfunction, like renal dysfunction, adrenal or renal or acidosis, or an overlap of multiple physiologies at play. And we see this relatively frequent when you obtain a functional echo in a baby. For example, you have a preterm infant that has this vasodilatory physiology, like the one example that I showed you, but also has a significant shunt. Or an infant with acute pulmonary hypertension that also has low systemic blood flow due to dysfunction of the LV, let's say. So it's essential to prioritize the line of treatment, and this is better done with an expert in hemodynamics and an evaluation. And just as a note, as a side note, that also your hemodynamic instability may be related to worsening of other organ performance, such as hypoxemic respiratory failure, where you have a parenchymal lung disease at play that you should always think into. Obviously, the both organs are in the chest for a reason. They impact each other. As I promised, as far as having, if you don't have the luxury of having a TN echo or a person that's trained in hemodynamics and at your hand, this is a great resource that I use it all the time, and I shared it with my staff and my fellows. And I'll leave it for a second. And then a second resource that I mentioned earlier, it's a great pathophysiology kind of specific algorithm. And then another version of my Vasoactive medication list and the effects. It has a little bit more information that I use a lot as well. So as guiding principles, that you should tailor your treatment to the etiology based on what your pathophysiology of the disease you have in front of you. Remember, the neonatal cardiovascular physiology is complex and it's very dynamic. It changes quite frequently. The sciences that we have is often extrapolated from animal studies, adult and pediatric studies. So that's why we have a widely variable practice. And I would say if something doesn't work, then please reevaluate and think of what else can be done. Thank you again. I'm leaving you with this thought, and hopefully I was able to convey that hypotension does not equate circulatory failure, and we have to think of all the parameters involved. Thank you again. Any questions?
Thank you so much, Dr. Prelipcean, for a really enlightening conversation surrounding this really complicated topic. And everyone, please feel free to unmute yourself and ask your questions. Right now, time for a Q&A, or if you like, feel free to post any questions you have in our chat box as well, and I'm happy to go over them. So it looks like we have one question here in our chat box here about instead of pulmonary hypertension when we're on moderate vasoactives, like for example, vasopressins or no epi, which that seems to be optimized. Is there any utility in adding milrinone in this setting to help?
That's an excellent question. And the answer, the short answer is yes. I think it's milrinone it's helpful if you think about, and of course we're studying milrinone and, for example, our CDH babies that have acute pulmonary hypertension, and we'll probably learn more about how it is useful or not. But in clinical practice, we get in those situations where we have a baby with acute pulmonary hypertension that we need a further effect on vasodilating the pulmonary bed and decreasing the pulmonary vascular resistance, and milrinone can do that. It will, of course, decrease your systemic vascular resistance, so you have to keep that in mind, and you may need to augment that in that case. But it definitely is another tool that you can use for acute pulmonary hypertension.
And as a follow-up to that, can you comment on arrhythmic side effects of some of these vasoactive medications as well, and which one we should be more mindful of?
Yeah, that's also a good question. I had it in one of my slides, but it, pretty much, I would say the one that I would think that could potentially dopamine, dobutamine, or the beta one agonist could, in theory, at high doses cause arrhythmia. For epinephrine at high doses, whenever we have to go to very high doses, I would be very cautious that it can cause arrhythmia. I haven't personally seen it. Luckily, I guess we haven't, had to use super high doses, but it certainly is a possibility. There's also a possibility with dopamine, and also a possibility with dobutamine. But epinephrine would be the one that I would think of more so at high doses.
Um, and the question I have, I think you kind of already highlighted, but I think in some centers we're lucky to have hemodynamics teams who are skilled at doing TNA. But as most centers, at least in US as of right now, we don't yet have that capability throughout. And in that settings, what would you recommend how should they think about hypertension and choosing the vasoactive medications when we don't have TNE capability?
Yeah, that's good. That's a good question, because like you said, it's hard. We don't have that capability in all the centers. And I've shared some of those. That's the reason for sharing some of those algorithms that are based on kind of the physiologic, some of the cardiovascular determinants and and the hemodynamic parameters available. And so those are very helpful to use. We're pretty good, obviously, when we're able to use all those parameters to potentially guess at the right physiology. When we have a combination of those kind of different physiologies, and it becomes a little bit harder without having that functional echo available. Of course, always think about what is the suspected etiology, and what's the pathophysiology behind it, and how can you manipulate your blood flow again, and your shunts, if you have them, to be able to help that physiology. NIRS, of course, it's another tool in kind of this non-invasive cardiac monitoring, I guess. It is not used in as far as, outside research, is not used in units necessarily, but that would be a fantastic add-on to our other parameters that we use, such as, of course, heart rate, capillary fill time, urine output, all those parameters.
Perfect. And just to follow up on your point, in neonatology practice, we've been using dopamine for a long time, and certain settings, not as open to changing that practice. So question is, what would you advice be for that? And especially there's one specific questions about dobutamine, and if there's good references to the use of dobutamine specifically for ELBWs and HIE populations, for our colleagues to get buy-in from the centers.
Mm-hmm. I think that, the shift away from dopamine, it's partly driven by this recognition, obviously, that there are potential side effects and of this variability in action that we can't really control. In cases of, for ELBWs, so there is that, there's small studies, but there are, a couple of small studies looking at dobutamine versus dopamine. And it's certainly with dopamine in preterm infants, you don't have such a robust increase in blood pressure, but you do get the increase in cardiac output. Now, it's hard to see that effect clinically. So I guess it all depends of what is your outcome, that you want to achieve. Is it raising the blood pressure, or taking care of that circulatory failure, which you have at hand. And I think that's the hard part, is to choose a drug when you don't necessarily see, in front of your eyes that blood pressure go up. But it definitely, using dopamine can increase your cardiac output. That's ultimately your goal.
Can you kind of illustrate this point a little bit in one of your examples, but can you talk about like volume resuscitation in a setting of neck?
Certainly. I think, if you have a vasodilatory type shock, which that's what you see in neck, you absolutely are, not that your overall circulating volume is low, but your preload will be low because of the leak, the capillary leak. So using more volume is appropriate in that setting. It might not be enough. It might not be sufficient. So you have to increase your preload, and you can use volume for that, and also be able to have some kind of vasopressor effect at your periphery to stop that pathophysiology of capillary leak. So both of them, but it is absolutely okay in those cases, even of a smaller baby, to use fluid to augment that preload.
So it looks like those are all the questions that I have in the chat box. Again, feel free to drop. I think we have a few minutes. I do have one question that I like to ask. You highlighted the importance of hemodynamics appraisals. I think that's a really important concept. And you talk about the limitations in the blood pressure. But are those numbers still helpful? Do you still use them? Do you still have certain target, especially when you're communicating with your nursing staff about what you're looking for and when you should be concerned?
That's a fantastic question, because I think, although hopefully I illustrated that we don't know what hypotension and what blood pressures are in our population, it is important to have some parameters, right? It is an imperfect surrogate for cardiac output, and hopefully I made that clear in organ perfusion, particularly in neonates. But I think in clinical practice, you should focus on maintaining this blood pressure, again, above a certain floor threshold. That's how we communicate. So you have to, like you said, in order to, tell your nurses, tell your sort of, people who take care of the babies right at bedside. So I think it's, okay to use those normative data. I would not recommend just using the mean arterial pressure. I think I want to, make that point clear. So reference those. They're not perfect, but reference those values that we have that are, broken down per gestational age, and systolic and diastolic pressures. So I would make sure, you're kind of aware of what the third percentile or the threshold that's published out there for the gestational ages, and try to stay above that. Of course, the reliance should not be solely on absolute numbers, and hopefully I made that clear. It's the trend in those numbers, and then of course all your other monitoring data, your lactates, your all the comprehensive picture that you should evaluate and reevaluate.
Okay, looks like those are all the questions I have for today. Just a reminder, everyone, please leave us an evaluation. I have shared the link to our RedCap page here, and you can skip the questions of which lecture you attend, and we will know by the date of today. And of course, these videos will be uploaded on our website. Feel free to reference this later. And I'm sure Dr. Prelipcean will be welcome for anyone who have follow-up questions or want to contact her for additional information. But so thank you so much for joining us today. I hope you learned a lot, and this was a valuable learning experience for you all.
Thank you.
Thank you.